This is my hospital in Cairo. I'm the Professor Sameh Tawfik, Head of Pediatric Department at Mahdi Hospital and Professor of Pediatrics at the Military Medical Academy. And my topic today is neonatal thrombophilia. Actually, the incidence of venous and arterial thrombosis in neonates is approximately between 2 and 6 per 1,000 NICU admissions. Thrombosis is significantly affecting both full-term and preterm infants. And sepsis is an important factor in predisposing to neonatal thrombophilia. Newborn have a greater risk of thromboembolism. Venous thrombosis is manifested clinically by edema and cyanosis, and arterial thrombosis are clinically manifested by pallor, cold limb with absent pulses, pain, seizures, sometimes require ventilator support. Anticoagulant levels in the neonate, for example, antithrombin 3, protein C, protein S, and plasminogen are low. So there is a tendency for neonatal thrombophilia and thrombosis. These are the factors in which we have to look for. Factor 5, leading deficiency. Factor 2, G2021-0 gene mutation, and methyl tetrahydrofolate reductase deficiency, protein C, protein S, etc. Initial evaluation is a routine, including CBC, BT, BTT, fibrinogen, protein C, and protein S, activity levels, and antithrombin activity, and plasminogen, and factor 5 laden by gene mutations. The management of neonatal thrombophilia or neonatal thrombosis are 5 major categories. The first one is thrombolysis, second is anticoagulant, nitroglycerin, supportive care, and surgery. Management should be done in tertiary referral hospital where pediatric hematologist with an experience in thrombosis and vascular surgeon and pediatric surgeon and radiologist. Anticoagulant are 2, unfractionated heparin and low molecular weight Clexane, which is given sub-Q. So we have heparin and low molecular weight. Heparin requires intravenous line and short-term, it is short-term anticoagulant, durations between 3 days to 3 weeks if surgery impending. And Clexane, it can be given subcutaneously, fewer side effects, but long-term anticoagulant. And this is a preferred line, our preferred drug in our NICUs. And there is low dose of recombinant tissue plasminogen activator. And the dose is titrated up to 0.24 milligram per kg per hour, where treatment for up to 4 days, 96 weeks, or resolution of the thrombus. In the meantime, is infusion of 10 units per kg per hour of unfractionated heparin to prevent clot extension. Effectiveness in the neonate can be impaired by low plasminogen. That's why we have to get fresh frozen plasma before therapy. If we see these figures, we can see the clot before recombinant TBA. And following the recombinant TBA, we can see the blood flow is going fine in the aorta. Dramatic change. I have some cases, so I would like to share them with you. First patient came to my center in January 2012, day 12 of life, with color change for right little and ring fingers, as you see in the photo. 1 day after, there's a blackish discoloration of the right foot and left elbow. Antenatal, just consanguineous parents and history of abortions in the first trimester for this couple. But Past history, there was an hematuria, as mentioned by the parents at day 4. Examination was active alert, weight 2.9 kilograms, circumference 36, on the 75th percentile, no signs of dehydration, heart was normal, and no evidence of congenital heart disease. Examination, neurologically, Moro, grass, and cyclic reflex all were positive, normal. The limbs, there's a black discoloration for right little and ring fingers and left elbow and small area of the dorsum of the right foot. Investigation was normal, including INR and BT and BTT. TLC was 21,000. And chemistry, apart from D-dimer was positive. Unfortunately, we didn't the quantitative at this time. It was about 10 years or 8 years ago. But when I did septic screening, blood film, there was fragmented RBCs with toxic granulation, and CRB was 96 milligram per deciliter. TLC 21,000, urine culture, no gross, blood culture, no gross, no organism as well. At day 18, we measured protein C. We did thrombophilia screening for protein C, protein S, and antithrombin 3. And we can say that all of them were normal, apart from protein C and protein S were low normal. And actually, this time is not suitable time to assay protein C and protein S. But this was the first patient which I have seen and working with it. Anticardiolipine IgM was normal, and the anticardiolipine IgG was normal as well, and the homocysteine level was normal. Ultrasound, moderate amount of very nephric collection. It was a hematoma, and echocardiography was normal. We started heparin, loading those 75 microgram per kg IV and 25 microgram per kg per hour infusion, and antibiotics for the positive CRB and sepsis, which we have. And if you can see here, BT was 14.5, but BTT within hours, more than 20, about 12 hours was more than 100. So heparin was stopped, plasma was given, but soon we resumed heparin at a low dose, 12.5 microgram per kg per hour infusion. On day 3 of admission, the baby have hematuria. So hematuria, and he has thrombosis. So for us, and RBC is 70, and bus 3 to 5, and there's an albumin. TLC was 36,000. So the diagnosis was made as renal vein thrombosis. I'm sorry. Management, heparin increased to 55 microgram per kg per hour, and correlation profile was INR was still 0.9, and BTT was normal, unfortunately, and no response. On day 6, there was loss of pulsation on the left forearm, followed by bluish discoloration. Vascular surgery, recommendation, this is an acute ischemia of the left upper limb for urgent embolectomy. Operation was done for thrombosis of the left brachial artery at the level of cubital fossa, bypass graft using right lung saphenous vein. Graft wasn't working probably due to weak pulsation. After surgery, your output was 0.48 ml/kg per hour. Low molecular weight heparin clexane was given at a dose of 2 milligram per kg every 12 hours sub-Q, and antibiotics as well. And dopamine and dobutamine were given at 3 and 5 mic per kg per minute respectively. 3 hours following surgery, graft occluded, and the vascular surgeon set this patient for above elbow amputation. So I was in a panic at this time, above elbow amputation. This is something very serious, but I didn't give up. I consulted the pediatric hematologist and the consulted colleagues everywhere. for the advised recombinant tissue plasminogen activator. And at this time, we're depending on 12 on case series of 12 patients that's published years before we use it. And this is the recombinant tissue plasminogen activator. We started at the dose of 200 mic per kg per hour infusion. We can see the doublets of the left arm. There is a following RTBA patent operative graft with biphasic flow inside the distal radial and ulnar arteries with multiple collaterals. And you can see this doublets. This is very nice. The flow is going on. Unbelievable. If you can imagine that the first conversation, he said, don't worry, only a few days, it will be converted to dry gangrene and it will be amputated by itself. Nothing more. Cranial ultrasound, hugely dilated ventricles of the brain with brain destruction and cysts. At this time, it's only a few days, about 2 weeks following delivery. I assumed with my colleagues and my friends in the UK and the USA that this event, actually thrombotic events, has happened intrauterine. So this is huge dilated cysts due to thrombus. MRI, you can see this hydrophilic changes, you can see subacute hematoma, you can see subependymal hemorrhage, and the ventricles are huge dilated. There's an evidence of obstructive hydrocephalus. EEG, there was a focus. The baby was put on warfarin, day 1, 200 milligram per kg per day, oral, and day 2, the dose was decreased to 100 milligram per kg. And head circumference was 43.5, and ventricular arterial shunt was done for the hydrocephalus. Investigation, as you see, platelet count is normal, TLC is improved, INR is 1, BT 13, concentration is about 90, BTT is 26, bleeding and clotting time are normal. But if you can see here in this table, we have two things. The first is antithrombin 3 was 12, it was low. And the reference value for this lab was from 17 to 30. And factor V bleeding for the baby, there was heterozygous mutations. The diagnosis was made mostly antithrombin 3 deficiency with factor V bleeding heterozygous mutations. This baby actually was discharged home following the ventricular peritoneal shunt. Thanks God. This case number two at year November 2014, 4 days following birth, he presented to us with gangrene of the right hand, following with blue discoloration, following the insertion of intravenous cannula, and then localized to his hand. Refer to our unit at day 5. You can see this is his hand. Can you imagine? He came to my hospital for amputation, actually. Nothing more. And this is after perinatal history, maternal preeclampsia. That's it. But he has RG and he put in on nasal oxygen. Examination, just limbs were black, discoloration of the right hand. CBC was hemoglobin normal, TLC was 4.4, INR 1.3, BCT 39. Luckily, this baby was lucky that the Doppler of the right upper arm arteries were intact, brachial, radial, and ulnar pulsations. Management, give same protocol, giving heparin 75 international unit per kg per hour and maintenance 25 international unit per kg per hour. Antibiotics with limb elevation. Heparin was discontinued due to thrombocytopenia, and Throbex or uridine subcutaneously was given 1 milligram per kg every 12 hours for 3 days. And you can see his hand. Can you see the changes from the black discoloration improving day after day? Throbex was discontinued after 3 days, and low molecular weight heparin Clexane was given sub-Q 1.7 milligram per kg every 12 hours, and Throbex gel as well. This is his hand on admission, and this is his hand following the follow-up in the outpatient clinic. So he was lucky, and we were lucky as well. Case number 3, full-term baby girl, born in 2016, birth weight 4 kilograms, uneventful perinatal history, born by cesarean section. Cyanosis start at first day of life following IM injection, mostly connection. The baby developed cyanosis, coldness of the right leg, and the redness. Patients with medical advice in outpatient clinics, but no, actually there was no response. Or they said this baby is dead and we cannot make dead alive, and there should be an amputation. Examination on admission, he was active, conscious, with suckling, was post-mortem, and the vital were more or less normal, chest normal, cardiovascular no murmurs, normal, abdomen no organomegaly, abdomen legs. The limbs, there was an extensive gangrene of the right lower limb below the knee, and the right gangrene at the tip of the toes. Actually, I have photos for this baby day by day, as you can see, but I didn't put all the photos so to make it short as much as we can. So you can see the tips of the fingers, and you can see the gangrene, day 25, day 28, 30. On discharge, this is the baby on discharge. So we were lucky that this baby's limb has been saved. Echo was normal, duplex on admission, no flow at the dorsalis pedis artery. Popliteal artery couldn't be evaluated. Follow-up duplex on May 2016. Dorsalis pedis artery shows biphasic flow, and popliteal artery biphasic flow as well. The medications, Clexane, antibiotics, and now he was on warfarin. This is the limb in the outpatient clinic. So this is the third case, but I have one patient with complete obstruction or total obstruction with ACVC. Another one was left middle cerebral artery thrombus. Another baby with portal vein thrombus, etc. We have a lot of, in the last years, a lot of cases like this. And these are the patients in numbers and the details. More, I have here it is listed at 12, but they are more than 12. We have a survival rate of 75% for our series. And most of them died from infection, from natal septicemia, or congenital heart disease. These babies or these thrombophilia patients are rare, but they are there. And actually, we are working now on writing these cases so we can share our experience and share our Egyptian guidelines or Egyptian practice regarding thrombophilia, and trying to have protocols or guidelines for managing neonatal thrombophilia in my center. Actually, I would like to thank my team, nursing staff, lab, radiology, pharmacy, and this is my team in the old days, and this is my team years ago. And thank you very much indeed. It's short, but I hope it is clear.
Yeah, that's very interesting experience, Professor Sameh. I really enjoyed the presentation and really amazed about it's kind of close to a miracle that we see the